Okay, so let's get to the science, sir. Let's start with, does it actually work? I know that the studies that you talk of these are called meta-analysis, where you look at so many different literatures, pull them together to make a conclusion. There are so many meta-analysis studies done on ivermectin around the world. But I understand, at least in those that I've read, and in those that have been cited by doctors, even those who prescribe them, that in all the studies, ivermectin is actually taken with one or two other drugs. So there is no way that you can isolate whether the positive effects from the treatment actually came from ivermectin and not the other one or two drugs. What do you say to that, doctor?
That was excellently explained by Dr. Tess Laurie in a talk here in the Philippines about 3 days ago. You see, the drugs that you say that were with it, but not all the time, in some cases are actually given alone, have already been proven not to work. So if you have two drugs given with ivermectin and one drug doesn't work, then you have to conclude that it must be ivermectin.
Or could it be, sir, the reaction of the drugs together? Because I understand that I understand that one of the bigger proponents of ivermectin would be the FLCCC, the frontliners, COVID-19 critical care group they have in the US and the UK. They've been making a push for this. It's also been cited by some CDC members. And I looked at their papers, and this is what I found, that actually even FLCCC is promoting not just ivermectin, but ivermectin taken with other drugs. It's a whole cocktail of drugs. They call it MAF Plus. And I'm actually looking at the other drugs, and it's not just one or two other drugs with it. They have methylprednisolone, ascorbic acid, thiamine, heparin, ivermectin, vitamin D, atorvastatin, melatonin, zinc. Let me read this, famotidine, and therapeutic plasma exchange. So that's about 10, 12 drugs we're talking about. So how do we know it's ivermectin?
Yeah, absolutely. But there are many other studies that have been made. And let me cite to you over 80 studies that are science-based studies. And one of them is actually an in vitro study that I think you quoted a few days ago, where the ivermectin is one of the most effective in vitro against the virus. Around September last year, there was also a study which shows that ivermectin actually blocks the receptor sites of the virus onto our cells, therefore blocking it from ever getting into the cell. And you have over 26 as of today randomized controlled trials showing effectiveness, even as high as 89% for prevention and as high as 80% for treatment. So I think regardless of what the other groups are doing, you have so much science behind it. I do not see why we have to be so concerned about it.
Doctor, I understand some proponents think this works, that it is safe for humans. It's been here for 40 years, used by humans as well, but at what dose? Because typically, ivermectin is approved for usually 1 to 2 tablets taken per year. That's the dosage prescribed normally. But right now, the study that you cited, the in vitro, the Petri dish study done in Australia, used 20 times that dosage. So how did we come up with dosage indications, and could you tell us at what point is this dosage critical and can cause brain damage or other complications?
Yeah, Mimi, thank you for asking that question. That's always being mentioned as the high dose in vitro. But as I mentioned, it is already now showing, based on studies as well, that it can block the receptor sites of the virus to the cell.
But is it
and you have
at
over
a safe dosage?
8. Yes, these are dosages that not necessarily. It just demonstrated that it could block it. So it doesn't have to be at such high doses. But let me finish. There are 80 clinical studies. If the 80 clinical studies show positive response, and maybe about 2% only showing no response to ivermectin in clinical studies at the doses that we give, I think that should be enough proof that it works.
This is going to be the most explosive, the most important video I have done in the entire COVID series. Come on, let's go see what I'm telling. Hello everyone, Dr. Chris Martenson here. I am going to show you the explosive information that we have today on ivermectin. Stop the presses. This is it. We have it now. I know I've been talking about ivermectin for months and months now, but now all the data is in. There is no more excuse not to be using this. If your doctor, if your health provider is not providing you with ivermectin and you think you've been exposed or you have been exposed or you have COVID, they're guilty of malpractice at this point in time. Incendiary? Let's take a look at this and see what I'm talking about. Here's what I'm talking about. This is for all doctors out there, everybody in the healthcare provider space, anybody who's in the business of treating COVID patients, PAs, nurses, anybody, even if you're treating at home, you have to be aware of this paper that's come out. And this is review of the emerging evidence demonstrating the efficacy of ivermectin in the prophylaxis, that's the prevention of even getting it in the first place, and treatment of COVID-19. I've been on this for a long time, but thank you to these people here for putting this together. Beautiful, beautiful review. I'm going to cover just a little bit of it, just enough to make the point, but it's worth reading in its entirety. And if you're in the health space, you got to read this in its entirety. But before you do that, start giving your patients ivermectin. Full stop, just do it. All right, where are these people from? Let me get my drawing tool out here, my magic drawing tool. We've got Aurora Medical Center, University of Tennessee, Hackensack School of Medicine, University of Texas Health Center in Houston, Center for Balanced Health in New York. Just like the people who put together the Math Plus protocol, frontline doctors are doing this. The multi-tens of billions of dollar medical apparatus at the US government and also in the UK and in France apparently doing nothing. But that's an editorial comment for another day. Let's get now into this study. Check this out. This is a figure 2 from that paper. It says a meta-analysis, so that's combining the analysis of a bunch of different studies all into one place. A meta-analysis of mortality outcomes looking at death from clinical trials of ivermectin in COVID-19 hospitalized patients. So now we're talking just about people who are already in the hospital. So these are what we would call serious, if not severe cases. Okay. So look at this, all these different studies here, and this right here is saying what's the odds ratio. If the odds ratio is 1, there was no benefit, no harm. If the odds ratio is over 1, ivermectin, of course, would have done more harm than good. Under 1, and it does more good than harm. Every single one of these studies has an odds ratio of less than 1. And by the way, this is a log chart, so this is 0.1. This means there's around a 90% or better benefit for these 3 studies down here. 90% improvement in hospitalized patients. Now, the vaccine, 95% effective. You know what the vaccine's not effective at? If you're already in the hospital. If you're in the hospital, you give somebody a vaccine, no help whatsoever, right? So how do we treat people who are in the hospital? We use this. If this is not being used, it's malpractice at this point in time. Look at those odds ratios. The worst of these, is still better than remdesivir by an order of magnitude. And this is in hospitalized patients. What happens when we look at ivermectin as prophylaxis? So these are trials where people are either in a high-risk setting, they're healthcare workers, and or they've been exposed at home. And then they've been given ivermectin before they've shown any symptoms at all of COVID. And so the question is, well, how does it work under that scenario? Look at this. Here's the odds ratio of 1. Oh my God, all of these down are clustering around 0.1 or less. So there's a 90% blockage or better, roughly, depending on the study we're talking about. Blockage of developing COVID at all. Unbelievable. This is urgently important. You need to know this, everybody. And if you're a doctor, if you go to your doctor and you say, I've been exposed, I think I've been exposed, I'm feeling early symptoms, and they don't give you ivermectin, drop that doctor, go to the next one. You got to find it right now, because this is how not only you're going to prevent yourself from maybe getting COVID, the disease, but as I'm going to show you, it goes even further than that, maybe prevents you from having all of the horrible effects that we know come from getting COVID for the long haulers and the people who have mild cases who have heart conditions and brain fog and all that awful, awful stuff.
Because I got to tell you, every day of my life is something new happening in ivermectin. It's really a crazy and exciting time, and it's an honor to be at the head of it, because it really is the cure for COVID, and the more and more that it's being recognized, the more and more satisfying it is to see. Well, it's equally satisfying and distressing. For everyone who doesn't recognize it, it's distressing. But anyways, let's go over some things. So next slide. Yeah, I gave a talk a couple weeks ago on long haul COVID and ivermectin, because the emerging evidence is showing that ivermectin is a really key treatment. Now, I don't want to go over long haul COVID because Dr. Mobeen, you just did an episode of long haul COVID. Am I correct? He's frozen, but I know
So
yeah.
there is a echo. That is why I was on a mute. So this whole week we're talking about the long haul.
But tell me, did you talk about ivermectin and long haul?
Yes.
You did.
But I would love to have your thought as well, because we still are trying to figure out the dosage, the frequency, and then the mechanism. So
Perfect.
your thoughts are very welcome.
All right, I'm just going to go quickly over some of the slides. We'll just go to the treatment and the anecdotes. So I know you guys have covered it. Everyone, even newspapers, lay people are getting a sense of what long haul is, right? So go to the next slide. It's these persistent symptoms. And you know what I got to tell you, as miserable as I feel for the long haulers of COVID, I actually feel that all of the patients in history who've had this syndrome from other viruses and other infections, because it's not uncommon. EBV causes this, right? Mono, even patients with Lyme talk about this chronic Lyme syndrome. So other infections have caused it. And many patients are distressed because physicians don't listen to them. And you know why? There's very few objective signs. It's all a constellation of symptoms. And so physicians are unsatisfied. There's no good treatments. And so everyone gets frustrated with the plight of the long hauler. And this was from a patient. And I just thought it was a really poignant sentence where they said, I felt like no one was taking me seriously before. And because there was no historical medical evidence of COVID long haul, I just didn't feel like I had a voice that people would listen to. And I think that has been said by many, many patients in the history of medicine who felt the sequelae of these, post-viral syndromes. Next slide. It's very common. You can just go to the next slide, and I'll just go over. Right, we know the syndrome, right? It's a lot of these. I wouldn't say non-specific, but it's just hard to pin down, right? There's no signs of them. I mean, you say you have chills, you say you're tired. I can't measure that, right? Sometimes you'll have persistent fevers, dry cough, mild headache. That brain fog is so non-specific, right? People just feel like they're memory shot. They can't concentrate. They can't focus. And the saddest thing is that many people are actually have such a severe constellation of these, they're disabled. They can't go back to work. I'm in constant communication with actually someone from Paul's hometown, or where Paul lives, who's reached out to us, and he's a young man. He's, I think, in his early 30s, and he's essentially disabled, and he was very healthy beforehand. He's very frustrated because he just can't do nearly what he could do since he got COVID. So it's really a sad thing. Next slide. And we'll just go to next slide. That's just from a survey. You guys get the symptoms. And so, the question is, does ivermectin have a role? And so if you guys have talked about it, so this is what I know. And I got to talk to Dr. Aguirre Chang. So down at the bottom, he's like probably the only report that I could find where actually someone published, and I would say this is on a preprint. It's not peer reviewed, but he put on a preprint his experience, carefully detailing what he did with 33 patients who had symptoms present for more than 4 weeks. And so what he did is he did 0.2 mg per kg daily dose for 2 days. And he said that after 2 days, almost all of them, 88%, total improvement, everything resolved, which I find truly remarkable, even for a case series. I think those patients are, their function as their own controls, right? If you have symptoms for 4 weeks and you take ivermectin for 2 days, and 2 days later you feel really better, I don't know that you need a randomized control group there. I think you can do a pre-post study on that one. And if you're a patient, you'll swear by it. And what's interesting is, since there was a few that didn't report total improvement, what he did, just saying, this is his protocol, is he doubled the dose and he went for 2 more days, and he actually picked off a few more patients. So almost all of his patients reported total resolution of their persistent symptoms. So that's one way to approach it. So next slide. Then I got to talk to him, and he actually posted this not too long ago. And so he and I actually, I found him on LinkedIn. Obviously a really guy very, very interested in long haul. I think he's probably the leader. I'm looking forward to more of his publications, and I hope he does more detailed reports and or trials. But his new protocol, he calls it a test. I guess he wants to it's a diagnosis and a treatment. I like those kind of things, right? So basically, he does this test to find out, is this long haul COVID? And so this is now quite different, if you'll see, right? So 0.2 to 0.3 mg per kg twice a day for 5 days. He does aspirin. What I couldn't fully understand is he does aspirin for 3 days, then adds the ivermectin. Clearly he's treating inflammation here. In his writings, he is of the impression that this is persistent viral presence and viral replication. I actually don't think that's the case. I don't think ivermectin is acting as in its antiviral properties here. I think it's solely relying on its anti-inflammatory properties. But we can argue about that another time. As long as the patients get better, it's all good. And what he said is that he's found that his inexperience treating, and he's treated several hundred patients now, that the symptoms that respond the best are the sort of ear, nose, and throat, anosmia, nasal congestion, tachycardia, chest pains, night sweats, and then even the brain stuff, right? And so he says that if after 5 days of this combo, if symptoms improve by 40%, then he continues both until everything is resolved. So you have to show a response. And if you do, he pushes on, and I guess he's aggressive until you're better. And he says in about 300 patients treated, he says about 75 to 85% have responded. The ones that are most difficult are, he says, are the muscular or chronic fatigue. And there he's got a little cocktail which he uses, more variable. So that's a little less definitive what to do with those folks. And I think we need to learn more about them. So next slide. So those are two different protocols. Now, Fred Wagschel, who's actually part of our alliance, he helped, he was with us since the beginning when we first formed. His wife is on our PR team, and she's helped lead us throughout. And he's a pulmonologist, and he's been using ivermectin along with us when we discovered his efficacy. And now he's getting referrals. So people are seeking him out with long COVID. And not only is he saying it's the real deal in acute COVID, but now when he's getting these referrals with the long haulers, he's giving ivermectin 0.2 mg per kg. He does it daily for 5 to 7 days. And he says most report that in 3 to 5 days they're significantly better. And I didn't write it here, but just like Dr. Aguirre Chang in Peru, he says that about 75 to 80% of his patients respond when he uses this protocol. So there's a number of protocols that I gave you in the cool beans, Dr. Mobeen. Okay. Did you go over any of these things? Did you go over Aguirre Chang's papers, Dr. Mobeen, when you did?
No,
your,
we have not gone over these papers yet.
Okay, good.
So thank you very much that you are going through them.
Great. Okay, and then next slide. And so this is just, these two are just kind of anecdotes. I'm happy to share the slides later, or people can watch them, but they're just interesting. They're just really chronic and terrible symptoms that patients had, and then they took ivermectin. And again, this is one of those historical controls. I'm sorry, but when you have symptoms for up to 9 months, and then you decide to take ivermectin, and on day 1 you suddenly improved, you got two possibilities there. Number one, it's the most powerful placebo effect ever known to man, which is great. Take ivermectin, let it work as a placebo. Let it be fake news, okay? Or it's actually doing something. And this woman wrote to us. She just said that her fatigue faded into the background. It was so special. After the 3rd day, I was healed. I was so taken aback. I had to process whether this was actually the case. But then I could walk my dog, which was just not possible before. And if you go to the prior slide, Dr. Marmy, it's similar, or no, I'm sorry, the next slide, after Mitzi. Same thing is that this woman wrote to us saying that she just, started taking ivermectin. Her diarrhea, which had been chronic for a long period, got better. The fatigue started to go away. The cough got better. And she was just so moved that she wrote to us this really moving testimonial. I gave her the name Karen. I don't know why, because actually I didn't get her name. But she said, "I will be grateful forever for ivermectin. It gave me my life back. And I am once again the energetic 77-year-old woman who once ran circles around her husband and her children." I got to tell you, I mean, as a physician, I've had a lot of satisfying experiences, but this takes the cake. This is really good stuff. So let's keep going. And then this is just two colleagues, Dr. Osgood. He treated an old research mentor of his who just said he got really better. One of our supporters also found that the guy got off oxygen very quickly after ivermectin, after 3 doses. And so we're seeing just more and more, again, anecdotal reports, but so compelling, really, really compelling. And so, again, ivermectin is one of the safest drugs known in the history of mankind. One of the safest drugs known. No harm in trying this for someone as debilitated as someone with long COVID. So next slide. Again, this is another story. I won't keep going, but you guys can read this later. But again, just abrupt and pretty brisk responses after prolonged symptoms and taking ivermectin. Next slide. Same thing. I don't know. I don't want to keep going over all these. I think people either get it or they don't. But let's just look at what she said. 36-year-old woman, miracle. Understating it. I immediately felt better after my first dose. After my second, I felt great. Another dose 2 weeks later. Then I started to feel amazing. And actually, we can talk about this case because this case really made me think. And I'll tell you why. Is that she had Lyme disease in 2016, which effectively disabled her for years. And she was able to get out of the house, but she had a very poor quality of life. So for 2016 to 2019, she was doing really poorly. And then the poor thing, she gets COVID. And she recovered to somewhat normal. She was fatigued on weekends, slept all weekend, and she could only function 1 day a week by August. And so when her story is, she's telling us not only did she recover from her post-COVID, but she felt better than she had since her first illness, which led her into this post-illness syndrome. And so I thought this was as remarkable a story as you're going to hear from a patient. So very cool story, and I'm just happy for her. It really does sound like she got her life back. And so, again,
to quickly add, I'm going to mute your mic for a second so this echo is not there. For my own patients as well, or those cool beans who have been listening to my videos about ivermectin, I get so many messages back that I started using ivermectin because I had COVID, but then my pains, my joint pains or my muscle pains or my chronic illness disappeared. And now that I have stopped ivermectin, it is starting to appear. Those previous things are starting to appear again. And what is going on? Should I just continue now? It is acting like magic even on the previous or earlier or pre-existing conditions as well, which is magical.
Magical is true. It's so cool. You know, one of the nice little anecdotes I got a couple of months ago is, as you may or may not know this, but Paul and I started giving lectures in South Africa. I think he and I probably caused a revolution there because there's so much crazy stuff going on in South Africa around ivermectin. But you know, some of the people who invited us to talk, they started prophylaxing with ivermectin. And one of the guys that I know, he said that his niece, who had terrible chronic skin conditions, she started prophylaxing with ivermectin, and she said that her skin disease completely cleared up and she felt better than she had in years. And so, but that's actually known in the literature that ivermectin can be used. I think it's used for rosacea and some other skin ailments. Anyway, so next slide. So that's my little take. That's my little my 2 cents on long haul COVID. Again, I don't want to sound like Johnny One Note, you know, that the answer to everything is ivermectin. It very well may be the answer to everything, but it's certainly the answer to at least acute prevention, treatment, and even chronic COVID. And so, really, just a terrific drug and we needed one for this disease because this thing is bad. All right, so let's go over some updates. I think there was a momentous occurrence that happened last weekend, and it was what's called the BIRD conference. So it was the British Ivermectin Recommendation Development Panel, which met last week on February 20th. If you go to the next slide. And what happened was this evidence-based medicine consultancy group in the UK, and they've for years done systematic reviews and meta-analyses for the Cochrane Library, for the WHO. They've participated in many, and they've been hired to support and guide the formation of many guidelines over the years for many national and international health agencies. And they just felt that ivermectin needed to be looked at. And so what they did is they coordinated the development of this collaboration of 75 researchers, specialists, generalists, and even patient representatives. They asked for no financial support. Everybody volunteered to participate. And they followed the standard kind of WHO approach to evaluating a drug, its evidence, and formulating a recommendation. And so they followed it to the T. And so they did the group did their systematic review and meta-analysis. And if you go to the next slide, and that was the technical working group of the BIRD conference. And they presented their conclusions, right? So the technical work presented it to all the attendees. You can view it at that YouTube address. The entire conference, about 2.5, 3 hours long. And then the panel of clinicians, specialists, patients, researchers, they did what you normally do when you're assessing whether vet medicine should be adopted and recommended. And so they made assessments, they had a long discussion, and then they took votes on qualities of what are the desirable effects. So is it efficacious? Does it have undesirable effects? What is the certainty of the evidence? What is the values and preferences related to this medicine and therapy? What are the resources involved? Is it equitable? Can it be widely distributed? Is it acceptable and feasible? You guys get, it's a wide-ranging judgment of whether this should be adopted. And if you go to the next slide, this was the forest plot of the meta-analysis, just looking at the outcome of deterioration. So based on all these RCTs, they found a really strong and fairly tight treatment effect for preventing deterioration and for recovery. So that was one conclusion. Next slide, they also did mortality. I might have removed that, but there was a number of forest plots that they did there. But ultimately, the group near unanimously not only recommended ivermectin, they recommended it strongly. And I didn't put in all the recommendations, but if you look at the document, I'm happy to share with you afterwards, and it will be posted on their website within a week. But they also recommended in the prevention, so as a prophylactic agent against COVID, and in all phases of treatment. And so it was a really profound and near unanimous strong recommendation from an international group from all the regions of the world. And I just think that this document, it's being sent to the WHO, it's going to be sent to the NIH, to the FDA, to the Canadians, the Germans, the French. And so because if you look at all those regulatory bodies, they're just they're all negative on ivermectin, but none of them are actually looking deeply into the data as some of us groups have. And so I just thought that was a really tremendous feat, what that group did, what they put together, and the result is truly remarkable. So I think the cool beans should know about this. Things are happening, okay? It is going to be the standard of care for the treatment of COVID-19. I will go to my death saying that. Hopefully I won't die before that happens. The only question I have is, when will it happen? That's the only thing I can't answer. It will happen. I just don't know when. All right, next slide.
Again, muting you just for 1 second to add my comment here. In the US, Dr. Paul Marek, the momentum that you have started, and then going to South Africa, and then this news going out as well. So again, credit going to Clay's study from Australia, and then Dr. Alam from Bangladesh doing the initial, having the courage to do the initial treatments with this, and then your voice. And now this is spreading, spilling in the world. Even this bird meeting, I believe, is a consequence of what was happening. So here we have Dr. Corey, who is actually one of the leaders for this thing. So thank you very much for doing what you've done. And I'm going to unmute you. My apologies.
No worries. No, thank you. I appreciate that, Dr. Bean. Next slide. So, and these are just some other cool things. So this paper by Juan Chimie, if you guys know who he is, he's been doing these epidemiologic analyses. His paper was finally completed. He got some co-authors. They got some help from some researchers at Emory, and it's a very mature manuscript. It's on preprint. It's been submitted for peer review. I demand that everybody read this paper. If you want to know where the paper is, go to our website. It's on the middle bar. You'll find it. You can download it. Just read the paper. It is in my mind, every public health official in the world should read this paper. It shows definitive proof of natural experiments that have occurred, which shows the eradication of COVID where there's widespread ivermectin distribution. It's happened, and we've seen the effects, and these guys have measured it. They ruled out every confounder. It is an amazing, amazing paper. So I just invite everyone to look at that most recent version. An early version is what converted me, but the most recent one is insane. Next slide. So here's a cool story. So Juan Chimie, who's part of our alliance, so he does all these cool analyses. He's just watching everywhere in the world, wherever ivermectin is being adopted. He's looking at case counts and deaths before and after, and he's just shown, he has so many examples of these tremendous population-wide benefits. And what happened is the most recent conversion was the Mexican Social Security Institute, Instituto Mexican del Seguro Social. And that's kind of their main public health agency. And what they did in Mexico City is they decided to adopt a protocol where in their 250 testing locations in the Mexico City metropolitan area, using rapid tests, if you tested positive, you got ivermectin. And that was their protocol. It started on December 29th. Look at the next slide. So Juan, in late January, he tweeted and he did his first analysis. This is actually, it was before this, and I didn't include it, I'm sorry. But he did his first analysis somewhere around here, and he said, hey, Mexico adopted this December 29th. Let's see what happens. I'll tweet every week showing you the case counts. And this was hospitalizations. And so you see December 29th, and somewhere right after January, the hospitalizations peak, and then they rapidly decline. A week later, more. 2 weeks later, even more. This is February 23rd. It's almost back to the prior baseline. And so this amazing, really sharp drop in Mexico City of hospitalizations, and then the next slide shows the fatalities, excess fatalities. Same thing, you started to declines more and then declines even more. It's still going. So when you, and this is actually what Dr. Andy Hill, the consultant of WHO, he's been saying this, that his vision of the future is almost modeled after HIV, which is a test and treat protocol. Mexico City is leading the way in that concept. Test and treat. You're positive, boom, take these pills, and then look what happens. Just tremendous results here in Mexico City, and they're starting to really talk about that at the IMSS, and I just wish the rest of the world would listen. I wish everybody could do test and treat. We wouldn't be talking about COVID in about 6 weeks if we did this, if the whole world did this. Anyway, keep going. And then this is my palm to forehead things, just stupid things that I see, misunderstandings about the role of ivermectin, and I find them both comical and just frustrating. But let's go over some of the things that I've seen, which I've almost laughed at. So next slide. So this is the Infectious Disease Society of America, known not so affectionately as the IDSA. So these guys... they did the update to their ivermectin recommendation at the end of January. And in their eminent brilliance, they suggest, at the end of January, when Mexico City is basically curing COVID with ivermectin, these guys suggest against ivermectin use outside of the context of a clinical trial. They're going back in time. Not even the NIH is recommending that anymore, right? So, and then what I found just literally comical is that the sentence that I underlined. In addition, there were concerns about publication bias, as the available evidence consisted mostly of positive trials. Now, let's be honest. Publication bias is real, right? We've known for years that the clinicians who do experiments that are positive are much more likely to publish than if you find a negative result. Okay, fair enough. But here's my statement. Do your job. Go assess. There's ways of assessing whether there's publication bias. You look at clinical trials registries. That's the whole purpose of clinical trials registries, is that most journals will not publish a trial unless you registered it first. And it's one of it is for that reason, is so that you can remove publication bias. Guess what? Andy Hill, next slide. Andy Hill of the WHO, he has looked at every clinical trial registry around the world. They have done an assessment. There is no significant risk of publication bias. So this amazing finding of all these positive trials, guess what, Dr. Mobeen? It might be a real finding. Just putting it out there. Could be real. All right, next slide. And I'll come in towards the end. I got a few more funny/stupid observations.
So, sorry, I muted you for one more second. Today we have a technical issue that if we both have the unmuted mic, then there is an echo. But I wanted to comment in here as well. This is something that I have been saying from the very beginning, March, April, that the organizations, bigger organizations, they have resources, they have a duty, they have assumed the leadership, and they are not able to go and look at the evidence, assess it, or as you just said, do your job. Just doing their job will have the right outcome right in front of us. And we did not have to come in and start teaching these things if this was happening at the right areas. And we actually now have to put more energy in it because we are not taken as WHOs or CDCs or FDAs. So we have to push all of this while they could simply spread it out and act on it. So anyways, that's just my quick rant. I'm going to unmute you and mute myself.
Well, I am sorry you just said that, because now I got to give my own rant, further rant, because I find it amazing that you've been saying that since March, because it validates my thoughts. I totally agree with you. They have resources. It's what I call, you have one job. Represent us. Do something for us. I have been in societies of my profession, in the ACCP, American College of Chest Physicians, the American Thoracic Society. You know what the dues are every year? It's like $600 or $800. They have a lot of resources. They have foundations. They have grants. They could easily assign experts to do this work. Why does it have to be me, nights, weekends, not sleeping, running around, doing all of this? They could do it, and you're right, they would have more credibility. And the last thing I want to say about that is, when I read these national guideline committees, whether it's from Germany or Canada or even the NIH, and they say there's unclear quality of these trials, we're not so sure about these, and therefore we're not recommending it. I'm like screaming at the paper, why don't you go talk to the investigators? Go validate how they did the trials. Go assess the quality of yourself. Don't just dismiss it because it doesn't look good to you. It's like, do your job. So thank you for mentioning that, and I'm sorry if I'm ranting, but Dr. Mobeen, I don't know if I told you, but I'm originally from New York, and we have opinions and we express them loudly. It's cultural.
So I love it. Thank you very much. And I am going to mute you for one more second and add some more to this rant. I was counting. So I was trying to write a book about COVID as well. And I was looking at my own work and seeing how much work have I done in last 300 days. We have done now about 350 talks. So I wanted to figure out how much is the volume of work. And can you imagine just me alone, one person, with the cool beans here? I have gone over more than 3,000 studies and line by line highlighted, took the content, written it down again, then illustrated it for the cool beans and presented it. Just one person dedicated to this could go over 3,000 studies and do the work. Imagine the organizations with the resources and duty of doing this. If they were sincerely doing it, how much of a difference they would have made.
So that brings to mind, and this is a quote that I came across, and I gave it to Paul because it reminded me of Paul Marek, but it's actually a quote from Galileo, and it applies to you too, Dr. Mobeen. Is Galileo said, "In questions of science, the authority of 1,000 may not exceed the humble and careful reasoning of an individual." You have these massive institutions and they've gotten so much stuff wrong, but the humble and careful reasoning of an individual like Paul Marek, he has just done nothing but read. He's ingested, reams of data on COVID, more so than I think those entire institutions combined. And similar with you, your work output here is phenomenal. I wish they could match the work output. If they had 10 Mobeens or 10 Mareks in that place, forget it. We would have solved this months ago. Anyway,
or a couple of Corys.
I like a couple of soybeans, a king bean, and a poppy bean, and we'll get it taken care of. So anyway, next slide. And then this one is again almost comical. It's almost black humor, but these are two meta-analyses of randomized and observational trials. Actually, the top one is a collection of randomized controlled trials of ivermectin's efficacy in scabies. The outcome is relief of symptoms at 2 weeks. And if you look, it's a pretty strong signal, consistent, favoring ivermectin. Actually, this is backwards. This is actually ivermectin. They flipped this. But you'll see they found a statistically significant benefit for the treatment of scabies. This is in the WHO guideline document, where they recommend globally to treat scabies with ivermectin. WHO, I think this is either 2014 or 2018, I can't remember. So look at this meta-analysis. This is the one for our paper. Now, these are observational trials. These are randomized. This outcome is mortality. It's not relief of itching at 2 weeks, it's mortality. Look at this. Remember, the number 1 means no effect. If it reduction of that outcome. So the risk of dying with ivermectin, and this is the randomized controlled trials, is like 15 to 20% risk of dying compared to controls. And you have this really unique and reproducible profound benefit on death in COVID-19. Yet, where is our recommendation for use from the WHO? They did it in scabies, and where are they doing it in WHO? We're still waiting for that recommendation. How much data? What is this definition of sufficient evidence? This almost makes me angry. And so, one of our friends, Chris Martinson of Peak Prosperity, you guys, some of the cool beans, I'm sure, follow him. He's a really brilliant guy. But he made this joke. He said, oh yeah, you remember that worldwide pandemic of scabies where, it cratered the world and caused economic shutdowns and lockdowns and and the WHO saved us with their recommendation on scabies? And I said, oh yeah, I remember that pandemic. And so we're waiting for them to save us from a similar pandemic with COVID-19. I hope you guys get that really sad joke. Anyway, this is just unconscionable when you look at this slide. Next slide. And then here's just a couple of stories which I just found just too funny. So these journalists are writing, wonder why India has these plummeting cases and there's this dramatic fall in virus cases. What I'm sure the cool beans know is ivermectin is widely used in India. Now, the ivory tower folks in the capital, they don't believe it works. It's not on that national federal health guidelines, but the real guys on the front lines, they know it's working. They're using it everywhere. And so if you go to the next slide, this was even a newspaper article in India where they said sales of ivermectin jumped fourfold. So they're using it like crazy in India. But in those two articles, ivermectin was never mentioned once as a possible influence to the plummeting cases. Next slide. This is from Juan Chimie, and if you look, this is 3 states in India. So Uttar Pradesh and Bihar at the top. In northern India, Uttar Pradesh adopted across their whole state ivermectin treatment on August 1st. 234 million people live in Uttar Pradesh. 120 million people live in Bihar. And if you look at their numbers, right? So here you have Kerala in southern India, and they were approximating what it was like in Bihar, and they were a little under what it was like in Uttar Pradesh. And then things started to climb, right? Bihar had a little bump and then it went down, and Uttar Pradesh had a huge bump and then it went down, and now they're similar and they're the lowest in India. Look at Kerala. Insane, going nuts. And so these are huge populations in which ivermectin is ubiquitous, and they're essentially controlling the pandemic. Gee, Dr. Mobeen, I wonder what's causing this ridiculous drop in deaths and case counts in India. Who knows? I wonder what it could be. Go to the next slide. I'll show you what their theories were. This was from the paper. So I'm reading this and I'm just like laughing. It's not that India's testing less or things are going underreported. It's just been rising. And now suddenly it's vanished. I mean, hospital ICU utilization has gone down. Every indicator says the numbers are down. Scientists say it's a mystery. They're probing why India's coronavirus numbers have declined so dramatically and so suddenly in September and October, months before any vaccinations began. Next slide. And this next slide, I'll just go to the bottom one because it just like all their theories of why it should drop just didn't make sense to them. They said it's actually the opposite of what should be happening. And then 3 options. 1, it's gone because of the way people behaved, so we need to continue that behavior. Or it's gone because it's gone for some reason, it's never going to come back. Or it's gone, but we don't know why it's gone, and it may come back. So someday they'll figure it out, Dr. Moby. Maybe they should tune into this program, or you should blast this across India. So anyway, next slide. I think I'm coming towards the end. Oh, let's talk about the U.S. This is pretty cool. Paul saw this article in JAMA showing prescriptions of ivermectin. And so there was a little bump in the summer, but it's been pretty much stable, around 5,000 prescriptions. I think this is per week. And then suddenly, Paul's first lecture of YouTube was early mid-October. We put out iMask late October. My manuscript went on a preprint on November 13th. Right here is when I posted my preprint. And then my Senate testimony was right around here. And then boom, it skyrockets. So lots of people in the U.S., not enough, but many, many people in the U.S. are using ivermectin. Go to the next slide. And this is a table from that same paper. The number, so this was baseline number of prescriptions, and then this was the increase in prescriptions over baseline, and the most increased medicine prescription out of all of them being used was ivermectin, and the peak week was December 18th. And so in the last few months, the U.S., I think, a little bit under the table, right? Because it's not officially recommended. The IDSA doesn't want you to use it. The NIH barely wants you to use it. In fact, they didn't change their thing until mid-January. But guess what? It's like a revolution. There's some rebels out there. Some rebel physicians, probably cool beans. Probably it's all driven by cool beans, I bet. And so there are people using their lives being saved. And so, and I think I'm done. I think I'm at the end. Next slide. I think I'll just show a couple more about the U.S. Oh, this is our slide. So these are confirmed adoptions by national health ministries. We know that use, especially in the U.S., for instance, is skyrocketing in many places. We're hearing from people all over. But these are the official adoptions countrywide, and they're really increasing. Many of these have been in the last month. And so this is really satisfying. And you know, one day, like I said, this map will be all one color. But right now it's mostly South America, Central America. Mexico's increasing, but South Africa's there. Zimbabwe just ordered a massive importation of ivermectin into Zimbabwe. North Macedonia, God bless Slovakia. They are the renegade state of Europe, right? It's an EU country, and they bucked the Europeans, and they said, we're adopting this. We believe it works. And then obviously there's Uttar Pradesh and Bihar. And so I'm really looking forward to this map colors changing over time as we go forward. Very satisfying. Next slide. And then the U.S., yeah, that's another map. And then this is from the C19 study group. I love that website, that group that, you know, catalogs all the studies on ivermectin. Here they use different colors for like some, mixed, many, and countrywide. And so they're being a little bit more gratuitous to the U.S. I think there's definitely some regions in the U.S., but it needs to be more. Next slide. And then this is just some institutions that have been using it for a while that have adopted it and are already reporting just tremendous results. And then the next slide, this is just a smattering of big facilities, chains, assisted living facilities, or groups of assisted living facilities in multiple regions. We're just hearing more and more reports of adoption amongst hospitals. Again, done independent of the NIH. The NIH refuses to lead here, so there are some physicians and some healthcare systems and hospitals that are filling that void and showing leadership and good judgment. So God bless them. And I think that's it for me. Hey, Dr. Beam, before we go to Q&A, can I get a 30-second rest?
Absolutely. Please do.